patient with bilateral symptoms, either on the upper limb and or lower limb, neural symptoms. This could be indicative of a spinal cord involvement. And in this case, we might think about further examination to find out if the spinal cord is compromised or not. Instability between C1 and C2, and this is very common after whiplash injuries or trauma. So very simple, exclude the red flags by listening and by history taking process that's very comprehensive and detailed. Once we do that, as a standard, we have to start with active and passive range of movement testing. Again, repeated movement testing is a very nice and clinically relevant physical examination procedure that we can use, asking the patient to move to different directions, find if there is any preferred movement towards a specific direction that decreases the patient's symptoms or centralize the patient's symptoms. Centralize again means moving the symptoms from the hand to the forearm, to the arm, and then to the neck. So repeated movement testing will help us to find the direction that decreases the patient's symptoms, then we can use it as a treatment strategy. Once we apply the repeated movement testing, here comes a role of assessment of the myogenic structures to assess how the patient moves. If he actually moving everything from the upper cervical spine, or he actually distributing the movement over the upper, middle, and lower cervical spine. And accordingly, if we find that he is not controlling the movement from the different areas of cervical spine, we might provide him in our treatment with movement strategies, exercises to activate a specific group of muscle, in particular, deep neck flexors. So far, you can tell that our assessment process is very beneficial and very clinically relevant. Why? Because for every assessment strategy we use, it will guide our treatment selection. What if this patient has neural symptoms? We need to know if this neural symptoms is related to compression of the peripheral nerve, or is it at the level of the spinal cord, which is at the junction or the connection between the nerve root and the spinal cord, or is it actually related to compression of the peripheral nerve at the periphery, upper limb? Here comes the beauty of the neurodynamic testing. By applying neural tension testing, we can find out the site of irritation or the site of pain. And accordingly, we'll decide if our treatment will be targeting central area, means moving the neural tissues around the spinal cord, or targeting the peripheral neural tissues, which is releasing the interface or the tissue surrounding the nerve on the upper limb by moving these structures to improve the mobility of the nerve, or by providing some neural gliding exercises in order to increase the mobility of the nerve in relation to the interface or the structure surrounding. That's mean it looks like, again, the process is systematic, assessing the movement, assessing the mobility of the neural tissues, assessing the status of the muscles surrounding the neck area, and make sure that they are actually moving in a healthy pattern. And from our assessment, we'll select the right treatment strategy. Most commonly, our treatment should be a package that include arthrogenic structures treatment, which is mobilization, either mobilization, passive, mobilization with movement, or both. This also could include exercises towards a preferred direction, but also it may include mobility exercises for the peripheral nerve, and definitely should include activation of the muscle surrounding the neck. Again, we will not really get the long-term treatment effect unless we include neurophysiology education and encourage our patient to move through our assurance strategies.